Now doctor, tracts of the spinal cord. In 1991, when I joined medical school, neuroanatomy professor used to take a piece of chalk and draw it on the board. All the diagrams by the time we go to the anatomy lecture hall. But today is all the modern times of iPads, finest gadgets. You can have a cochlear implant also, which can be able to give you a visual imagery to draw a diagram in the exam hall, right? So doctor, what are the tracts of the spinal cord? First of all, what is meant by a tract? Tract has a common origin, common termination. Suppose if I say a dorsal column, any dorsal column basically starts from the spinal cord. It has got a first order neurons, and ultimately it need to end up, whether it comes from sacrum or lumbar or cervical, any area, ultimately it need to end up in the nucleus cuneatus or gracile nucleus in the medulla. So common origin, common termination makes all the tract become a common tract, right? Even if somebody failed in anatomy and behind by 6 months, we still call him classmate. We don't call junior, no? So because the common origin is there, maybe 6 months here and there, he might have failed 6 months. Ultimately, we may take 6 more years to get seat in MD, and he may get it in first attempt. So ultimately, tract is common origin termination. They are all symmetotopically organized. There is a queue in which the fibers get packed in the spinal cord when a tract is there. Why is it important? Suppose if the medial fibers are coming from sacrum, from medially if there is any compressive lesion, then the sacral fibers are the ones which get first affected and the limbs get later affected. Chumma, I am saying you an example. Suppose if the medial fibers are from the limbs and the lower limbs come from or packed laterally, then a medial lesion will first affect the peripheral muscles. Hence we need to know, in the dorsal columns carrying touch and vibration, how are the fibers coming from the lower limbs, trunk and upper limbs are organized, and the pain and temperature carrying spinothalamic tracts, how are they organized? Already you know how are they organized in the Andrehorn cells. How are they organized? Medially located groups are all axial and laterally arranged are all appendicular. Thank God. Axial is central, appendicular is lateral, no confusion, no terminology problem. But there will be few terminology problems here. We will take that. Now, this is the whole story, doctor. Ascending, descending tracts. We have motor descending tracts coming from the brain. Lateral corticospinal, anterior corticospinal. These two are called pyramidal tracts. Where is the pyramid? Is it? Brain. Brain may you have cells of beds. It is not medullary pyramid. Oh, you want to say medullary pyramid? Lower part of the medullary. Yeah, some say even because of that because it has to pass through the pyramid in the medulla. But pyramidal cells of beds is a complete name for the motor cells in the motor cortex. Right, doctor? So, pyramidal tracts. They send the fibers which will control Andrehorn cell. Arey Andrehorn cell, heart, aage bado. If it says from the brain, it communicates through the corticospinal tract. But suddenly, whenever you have done agitation in medical college, कोई बोलता है पत्थर ले लो और बस को मारो. Another fellow will say, don't do that. 14 years you will be in the jail. So in your hand you will have a stone and suddenly one will be saying from the ear. You don't know what to do. You will be hitting yourself with the stone. So you corticospinal and extrapyramidal. They both will be trying to control the androchonsal. So what are the tracts which are called extrapyramidal, which is not corticospinal, and which is not corticospinal? Corticospinal mein two types are there, doctor. Lateral corticospinal, androcorticospinal. Be sure. The red nucleus. Where is the red nucleus? Yesterday we discussed. Midbrain, superb. Reticulospinal. Where is the reticular formation? It is there throughout the brainstem. Then olivospinal. Where is olivary nucleus? Inferior olivary nucleus is a beautiful nucleus located in pons. If you say pons, I will commit suicide. Yesterday we discussed it, doctor. What is that answer? Medulla. We were discussing, no, doctor, medulla, how it communicates with the cerebellum. Right? I did MD General Medicine. For your sake, I learned anatomy and coming and teaching. Be very sure. Slightly be little courteous. Go through the yesterday's class. Don't go through. After telling you doing mistake is deplorable, doctor. Alright. No problem. Chumma I am saying. Don't worry. So olivospinal. Then we have vestibulospinal. Why this vestibule? Because ear keep telling, this fellow is falling, this fellow is falling, this fellow fallen. Oh, you are falling. The vestibular nucleus will tell the androchonsal. Then androchonsal will try to stand up. So you require some input which need to come to maintain a balance from the vestibular nucleus. So vestibulospinal, olivospinal, reticulospinal, rubrospinal, this is all called as extrapyramidal. And lateral corticospinal, androcorticospinal are called as pyramidal tracts. These two are basically called the descending tracts is what need to be remembered. Then what are the ascending? We have dorsal columns and a medial lemniscus, which is called dorsal column. Then we have spinocerebellar tract, posterior and anterior, which bring pain and temperature. Then we have a anterolateral spinothalamic tract, and then we have a spino-olivary fibers, which will keep telling medulla, and ultimately they will be telling cerebellum what is happening in the spinal cord. Spinocerebellar tracts are all there, no? So before passing while passing to the cerebellum, they will also keep informing the olivary nucleus. So you have spinocerebellar tracts which are also ascending. Let's take each of them. Typically the ascending tracts will be conveying the sensory information coming from our muscles and the viscera to the higher levels of the neuraxis. They contain three orders of neurons: first order, second order, third order. All ascending tracts, basically their first order neuron is located in this dorsal root ganglion. Ventral root has no ganglion, sir. Only dorsal root has a ganglion for the people who came little late to today's class. Then they ultimately decussate, the ascending tracts. Where they decussate differs. Dorsal columns will go ipsilaterally until medulla, and there they will decussate into the medial lemniscus. Whereas the spinothalamic tract will decussate right at the level of the spinal cord only. Right? So they decussate ultimately before reaching the final destination. None of these ascending tracts will reach the ipsilateral side in the brain. They reach the contralateral side in the brain. That's the point of interest here, ultimately. Now there are 6 major tracts which are very important. First is the dorsal column, otherwise called medial lemniscus system. Why is it important? What is it carrying? Tactile discrimination, whether it is an ant or a scorpion or your boyfriend's finger, what is creeping under your palm, you must be very sure. After biting, if you know, there is no use when you are sitting in the grass in the medical college. So tactile discrimination is basically dorsal column. Then vibration and the form recognition. If I close your eyes and put a 10 NP coin, you must say, nowadays 10 NP is not there. 100 rupee coin, you must be in a position to recognize what it is. Then joint muscle sensation also. And the conscious proprioception also is conveyed by the dorsal column. There is one more type of proprioception. What is that called as? Unconscious proprioception. Who carries that? We will take it up a little later. Earlier we mentioned it. Then, what are the end receptors from where this information of proprioception, touch, discrimination, fine point, fine touch, everything will come, doctor? Pacinian corpuscles, Meissner's corpuscles, joint receptors, muscle spindles, Golgi tendon organs, they all ultimately merge into the dorsal column. Now, what are the first order neurons? Typically, the first order neurons are all located in the dorsal root ganglion at all levels. They give rise to fasciculus gracilis when the information comes from the lower limb, and they give rise to fasciculus cuneatus when it comes from the upper limb. Then, from these first order neurons which are located in the dorsal root ganglion, the axons will be ascending up in the dorsal columns in the white matter, in the spinal cord, and they terminate in the gracile and cuneate nuclei if you take the cut section of the medulla. Then second order neurons, where are they located? In the gracile and cuneate nucleus in the medulla, in the caudal medulla. And they give rise to the axons, and they will also give rise to these axons, which are the internal arcuate fibers, they are called. They decussate and they form a bundle when they decussate, which is then called as medial lemniscus. And the medial lemniscus will ascend the contralateral brainstem ultimately to reach the thalamus. And in the thalamus, where will it be reporting? Thalamus is the bedroom where all sensory afferents will reach thalamus. From thalamus only, all sensory relay will occur to the somatosensory cortex. Ventroposterolateral VPL nucleus is the place where they will be reporting. And from there, the third order neurons, hence VPL nucleus in the thalamus is called third order neuron. From there, they typically pass to the internal capsule. Once more, internal capsule, what does it have? Anterior limb, genu, posterior limb. Yesterday we discussed, So through the, which limb does it pass? Through the posterior limb of the internal capsule. Typically it will be passing and ultimately reaching the postcentral gyrus, which is the somatosensory cortex. And what is the area called as? Area 3, 1 and 2 is the ultimate reporting place. So this is all the way you go up in dorsal column. So what are the buzzwords we may forget in the exam? Area 3, 1, 2 somatosensory. It is not 4, 5, 6. Then it is a post-central, not pre-central gyrus. It is VPL nucleus, not APL nucleus. And it is the medial lemniscus, not lateral lemniscus. Lateral lemniscus is with auditory pathway. So these are the things that we need to ultimately remember. Now, doctor, spinothalamic tract. Typically, there is one lateral spinothalamic tract and there is one ventral. Together they constitute what is called anterolateral spinothalamic tract is what you need to basically remember. Now, what is the main purpose of this ventral spinothalamic tract? The light touch. If I take a wisp of cotton and make you feel it, how is it carried, doctor? It is by the ventral spinothalamic tract. So it is the Merkel's tactile disc and the free nerve endings which bring the sensation of that light touch like the wisp of cotton, which is carried by the ventral spinothalamic tract. So where is its, any first order neuron of an ascending tract is basically located in the dorsal root ganglion, उसमें tension कुछ भी नहीं है. Then second order neurons, where will it decussate? Will it wait until medulla? No sir. It will basically decussate in that ventral white commissure. We studied, no? We have one, how is white matter organized? It is one ventral funiculus, dorsal funiculus, and also there is a ventral white commissure where these decussating fibers are located and they reach the contralateral ventral funicule, and that ultimately go up and reach the thalamus non-stop without stopping anywhere, and thalamus becomes the third order neuron. And they typically project, they also project to the posterior limb of the internal capsule through that only, and ultimately reach the postcentral gyrus, which contains 312. And what do they mediate, doctor? The wisp of the cotton is what is being mediated by, light touch is mediated by ventral spinothalamic tract. Here comes the whole secret of remembering difference between lateral spinothalamic versus ventral spinothalamic. Ventral spinothalamic basically carries light touch, free nerve endings, Merkel's disc. These are the things which we need to remember. Whereas, if you take the lateral spinothalamic tract, the itch, the pain, the temperature, they are carried by the lateral spinothalamic tract. Whereas, light touch, wisp of cotton is equal to ventral spinothalamic tract. Together they form ventrolateral ke bina, what is the other name given? Anterolateral spinothalamic tract together. So you should know this fine difference. Then what else you need to know? Just like Merkel's disc and free nerve endings are important for the anterospinothalamic tract, no? For the lateral spinothalamic tract, what is important? It is the slow conducting fibers. Pain is carried by C fibers. Fast conducting pain is carried by the A delta. And we have the receptor specialized for the thermal temperature. And we have free nerve endings to bring pain. So receptors are free nerve endings and thermal receptors. And the type of the conducting fibers are basically belonging to the class A delta and C. And what is the difference between A delta and C? Both of them are pain fibers. But A delta is fast pain. C fiber is a slow conducting pain. And how is their somatotopic organization? Once this spinothalamic tract fibers enter into the spinal cord, how are they organized? The pain in the sacrum is located more laterally. The pain coming from the neck, cervical area, is located more medially. So if you look at the lateral spinothalamic tract, how are the central fibers, cervical fibers, doctor? They are more ventromedial. Sacral fibers are located more dorsolateral. Now tell me, if you are having a lesion compressing the spinal cord, not coming from center but from lateral part, extramedullary compression if it is there, then which fibers get affected first? Pain and temperature from the sacral area is gone first. But if you have a syringomyelia like lesion, which is expanding, central canal is expanding and destroying the cervical fibers first, then thoracic fibers next. So you will have a typical distribution of the loss of pain, temperature and syringomyelia in cape distribution. The neck, the thorax. So that is the distribution where you will have. Why? Because the spinothalamic tract may, how is the somatotopic organization? The fibers coming from the neck, cervical area are located more medially, and those coming from the sacrum are located more laterally, is what you need to remember. Then how is the fasciculus, gracilis and cuneatus, doctor? touch vibration we said, no? Typically the sacral fibers are located medially, opposite to that of the anterolateral spinothalamic tract. Cervical fibers are located more laterally. So this is the difference between the two. Any examiner is interested, if you can tell the somatotopic organization of dorsal columns and spinothalamic tract, means you understood half spinal cord neurology. Right, doctor? Because all lesions are explained. What is the challenge in a spinal cord case? Is it an intramedullary lesion? Is it an extradural or an intradural compression? Which is responsible? Right? So we have broadly what are the different types? Outside dura is extradural. Then inside dura is intradural. Within intradural you have two types. Outside the spinal cord but inside the dura means extramedullary intradural. And you are also having within the spinal cord means intramedullary. So which kind of compression, where is the lesion located, how will you know? Are the cervical, thoracic are first affected in the pain and temperature, or sacral is first affected? You need to see. If the cervical, thoracic in the pain and temperature are first affected, then it is more likely to be intramedullary, like syringomyelia. But if the sacral, lumbar are affected means pain and temperature, then that is coming from outside. Hence it is very, very important. Then doctor, how is this lateral spinothalamic tract organized? No tension. Dorsal root ganglion is the first order neuron, and they basically reach the dorsal horn by decussating to the contralateral side, which is the second order, and then from there they will be going and ultimately will be projecting onto the BPL nucleus in thalamus, right, which become the contralateral BPL nucleus becomes the third order. Now this lateral spinothalamic tract, when it decussates and goes up and contralateral side thalamus it reaches, two kinds of nuclei in thalamus it will go and innervate. What are they? One BPL nucleus, just like the dorsal columns, and that is contralateral side only, but bilaterally it will be innervating, it will be ending up in interlaminar nuclei of the thalamus. Then what is third order neurons? Ultimately are BPL nucleus and interlaminar nuclei. Why will it do like that? Basically, if you look at the pain and temperature, it is not that easy as that of the touch and vibration carried by the dorsal column. Touch is simpler sensation. Pain is complex sensation relatively. So this lateral spinothalamic tract, which is reaching contralateral BPL neurons in thalamus, it is reaching, no? They ultimately projected to the postcentral gyrus somesthetic cortex in the area 312. Precentral gyrus is motor, postcentral gyrus is sensory. In the sensory, we have the somesthetic area. Even dorsal column also reaches area 312, no tension. And it will also pass through posterior limb. Dorsal columns are also passing through posterior limb only. Dorsal column lemniscal system. Then what will interlaminar neurons will be projecting into? It is ending in thalamus, in interlaminar also, no, bilaterally. They will be basically projecting to the chorditoputamen in the basal ganglia and also to the frontal and parietal cortex. Why are we emotionally upset whenever there is a pain? Because if it is only reported to the sensory cortex, we won't be affected. But if it is also reported through basal ganglia to the limbic system, if it is reported to the frontal lobe, if it is reported to the parietal lobe, if pain is there, we tell the entire world there is pain. If there is a touch, we don't tell anybody who touched us. So that is the difference between the two. Now, we have a dorsal spinocerebellar tract. So what did we finish? Dorsal column is over. Spinothalamic tract is over. The next ascending tract. Dorsal spinocerebellar. We said conscious proprioception is carried by dorsal column. Unconscious proprioception will be there, no? When you sit on a table in the reading room, initially it is conscious feeling that you are touching the table. I just came late to the reading room. This table is very bad. My type of chair it is. This is not damn doom. After a little time, within about 1.5 hours, we get adjusted. We don't know that we are touching the table also, right? So that unconscious proprioceptive information must be told to cerebellum, and that is the purpose of the spinocerebellar tract. Any proprioception, conscious or unconscious, need to come from muscle spindles, Golgi tendon organs, and also unconscious comes from pressure receptors also. And the fine coordination of the posture and movement of individual muscles is basically because of this dorsal spinocerebellar informing to the cerebellum, the unconscious proprioception that is responsible for the posture and the movement of the individual muscles are very well coordinated. And it is an uncrossed tract, unlike the spinothalamic tract. Remaining things are very easy. First order neurons for any ascending tract is dorsal root ganglion. But we need to remember, how will they pass through the spinal cord? Which lamina through which they will be passing? Typically, for this unconscious proprioception, for it to pass in the spinal cord, nucleus dorsalis of Clark, we said no, in the grey matter. That is very important locus, is what I want to underscore to all of you. All the muscle stretch reflexes, afferents are reaching, no? They all enter into this dorsal spinocerebellar tract. Then second order neurons, where are they located? This is an interesting question. If this is an isolated MCQ, we can't answer in exam. What is the second order neurons of dorsal spinocerebellar tract? If examiner is very cruel, he can ask this. It is the nucleus dorsalis of Clark. C8 to L3. Unconscious proprioception ke liye. And that gives rise to what is called as lateral funiculus, the white matter part. And it will be reaching the cerebellum. How will it reach cerebellum? Cerebellum, see, whenever it ascends, where will it go to? From the spinal cord, it will enter medulla into pons. The route is straight, Hyderabad, Delhi. Beach mein cerebellum is like going to Rajasthan or Ahmedabad. Somewhere it need to come out of this Chennai-Delhi tract. So how will cerebellum and brainstem are connected, doctor? Inferior, middle, superior cerebellar peduncle. So it is the inferior cerebellar peduncle through which it will be entering into the cerebellum. Who receives it in cerebellum? It is the mossy fibers in the cerebellum are the ones which will basically receive. Ultimately, where will it reach cerebellum? For all our balance, it is the central part of the cerebellum. Vermis is very important. So it will be ultimately reporting to the caudal cerebellar vermis is what need to be remembered. So unconscious proprioception, coordinated movement of the posture, and receiving the proprioception from the muscle spindles, they are all the common functions of both the dorsal spinocerebellar and also the ventral spinocerebellar also is what I want to underscore to all of you. Both of them have got same functions. Only thing is dorsal spinocerebellar is uncrossed. Ventral spinocerebellar is a crossed tract is what you need to remember. Then for the dorsal spinocerebellar, where are the second order neurons are located? Dorsal nucleus of Clark. Whereas for the ventral spinocerebellar, right? Is the voice clear for the online students? Yeah. Just check whether the voice is clear. Yeah, right. So the ventral spinocerebellar tract has second order neurons. We said no, spinal border cells in our earlier topic. They are the second order neurons. And where will they ultimately reaching cerebellum? But they don't pass through inferior cerebellar peduncle. Rather, they pass through the superior cerebellar peduncle. But ultimately, they are also received by, after all, they are bringing information from spine, no? There is a receptionist sitting in the cerebellum to receive that information. Please come, sir, welcome, welcome. Who is that? Mossy fiber is what need to be remembered. And that will also be reporting ultimately to the vermis in the cerebellum. Now, doctor, we have the next important tract which is called as Cuneocerebellar tract among the ascending tracts. Just like dorsal spinocerebellar brings from the entire body, Cuneocerebellar is the equivalent of the dorsal spinocerebellar for the upper extremity exclusively. Hence, the first order neurons are in dorsal root ganglion, and just like dorsal spinocerebellar tract has one Clark's nucleus, the cuneocerebellar has got an accessory cuneate nucleus. So this is the typical accessory cuneate nucleus, and these are the proprioceptors coming from the neck, forelimb and upper trunk, and cuneocerebellar tract ultimately will also go to the cerebellum. So where are the second order neurons for the cuneocerebellar tract, doctor? It is in the accessory cuneate nucleus, whereas for the dorsal spinocerebellar it is in the Clark nucleus, right? So dorsal spinocerebellar enters to inferior cerebellar peduncle. Even cuneocerebellar also enters to inferior cerebellar peduncle, but ventral spinocerebellar enters through superior cerebellar peduncle. How does it matter? Finally, when a patient gets a degenerative disorder neurologically, whether it enters through superior or inferior doesn't matter. If the electrical connection is gone. There is nothing that you can bring back except writing multivitamin tablet to the patient and asking him to go home with a degenerative neurological disorder. But the neurology is not that, baby. Neurology is all the fun of what enters to superior, what enters to inferior, and whole ward round dragging is based on earlier days. The ward rounds may neuroanatomy, if it is not really good, it is a dance for a resident before a professor. So nowadays things are a little better. They are asking, did you follow up with the MRI? What decisions did you take? A little more meaningful human things rather than microscopic things. But anyway, for exam you can always remember what goes through superior, what goes through inferior. Now, if you look at the dorsal spinocerebellar or ventral spinocerebellar, they are all reporting to vermis. But our limbs se aa rahe jo cuneocerebellar, they will go and report anterior lobe of the cerebellum is what you need to ultimately remember. That's all the story, doctor, about ascending tracts. Let's talk about the descending tracts coming from the brain, commanding the anteroconsal, pyramidal, extrapyramidal. Quickly, 2-3 comments about each of them. We will go to the quiz round after this. Basically, we have somatic motor activity in our muscles, visceral motor activity in our viscera. They're all controlled volitionally by our motor cortex. So in the cerebral cortex, we are having motor area which is having the cells. From there the corticospinal tract is coming. In the brainstem we have the cranial nerves which are motor nerves. Some are mixed, some are motor. I mean, all are motor, but some are mixed. Of course, olfactory is purely sensory. right? And optic nerve is sensory. Okay, we can have sensory, we can have motor, we can have mixed, all right, doctor. But I'm talking about those motor nuclei in the brainstem, right? They need to be controlled by the cerebral cortex. So you have corticobulbar fibers and corticospinal tract are the very important descending spinal tract. Now let us talk about lateral corticospinal tract, which is called as pyramidal tract. One important thing is, what is the difference between we and we, the humans, versus giraffes or what you call? Buffalo's baby is called calf. I don't know, I'm poor in English. Cow's baby is called calf. Lion's baby is called cub. You have seen Lion King movie, no? Immediately from the mother's womb, they jump into the world, they start running. We are not like that. Mummy and daddy will come, and then in medical college also, during the exam, they will be swiping the sweat, and somebody will be massaging your back muscle, somebody will be doing the puja in the temple to see that you will pass exam. So, we are not that self-sufficient and independent right from birth. Why we can't just come out of the mother's womb and start walking? Because our corticospinal tract, pyramidal tract, which ultimately controls our muscle contraction, is not myelinated. It is not fully myelinated until our second year. That's the reason. So what is its main function? The volitional skilled motor movements, doctor, mainly the digits of the upper limb, most of our life depends on our fingers, what we do, what we write, what we do, anything. Then that ascending sensory pathways is there, though, even their sensory input also is modulated by the corticospinal tract. Then all this is arising from their motor cortex, which is precentral gyrus located, right? But a small part of this motor cortex will be descending down onto the medial surface of the cerebral hemisphere. What is that called as? Paracentral lobule. It is a strip of motor cortex. Instead of only remaining at the motor precentral gyrus, it slips onto the medial surface of the cerebral hemisphere, and it controls the contralateral lower limb movement, and it is supplied by anterocerebral artery. So this is what we need to know. From there is the corticospinal tract is originating, either from the motor cortex or from the paracentral lobule it is originating, is what you need to understand.